So I welcome Ariel Kane, who is our Director of Healthcare Policy for PPI.
Thank you. I have the honor of introducing the next panel for today. And as Michael said, I'm the Director of Healthcare Policy at PPI. When we think about healthcare, we have infinite amounts of data. We have data collected by hospitals and physicians. We have data collected by insurers and payers. We have data collected by electronic health records. We have data collected by the government. And then we have wearable devices that collect consumer and patient data. But this trove of data is not always used to improve policy or health outcomes. It's collected in different silos and often cannot be exchanged. But without harnessing the data to inform both policymaking and the practice of medicine, it becomes a drag on the system. Prior to the pandemic, physicians often cited the never-ending data collection of EHRs as the primary driver of burnout. Data should be used to demonstrate the value of what we're spending on healthcare, but it currently doesn't. We have a flood of data, but it's unclear if we have the right data or if we just haven't fully harnessed what we do have to illustrate the value of healthcare services on healthcare outcomes. So the question is, how do we use this wealth of data to help lawmakers make better healthcare policy and healthcare providers deliver better healthcare? Today, I'm introducing two speakers who are going to speak on that issue. First, we have David Cutler, Professor of Applied Economics at the Kennedy School of Government. David has served on the Council of Economic Advisors, the National Economic Council, and he was a senior healthcare advisor to Barack Obama's presidential campaign. He has held positions with the National Institutes of Health, the National Academies of Science, and the National Academies of Sciences. Currently, David is a research associate at the National Bureau of Economic Research. He is the author of numerous books, and he is here today to talk to us about health satellite accounts, which measure healthcare spending by the disease being treated rather than the drugs and services being provided. After David, we'll have Murray Aitken, the Executive Director of IQVIA's Institute for Human Data Science. Murray is an expert on how human data science can improve patient outcomes through managing costs and maximizing access. Prior to his time at IQVIA, Murray was a partner at McKinsey & Company and covering a broad range of industries, including life sciences and consumer goods. Today, he'll be talking to us about measuring pharma prices and how, with better data, the government can make better policy choices. With that, I will pass things over to David.
Thank you. Thank you very much. I'm trying to start my video, but it says I cannot start my video. Oh, the host has asked me to start my video. There I go.
There you go. Well, great to see you.
Great to see you. Thank you. Before starting, I do want to lodge a protest, which is that I think it's unfair that I have to follow Shane Greenstein and I have to precede Murray Aitken, because you're going to hear me and you're going to say, oh my God, why did I have to waste my time there when I could have been listening to more
I'm sure that won't be the case, but I'm going to turn off my video and hand things over to you.
So let me I'll do a little bit then introductory, and then I will really open it up. And let me first just make sure that you can see these slides as they're going by. Is that?
Yes, we can see them. Awesome.
And that's super. And then the other thing I want to try and do, if I can, is open the chat box, because I just want to be able that if I'm saying something that isn't making sense, just let me know, and then obviously I can. The point is to try and help people understand things. So I want to talk about data needs in the health sector. I want to do it, as Ariel said, in the context of what's called a satellite health account, but I need to sort of introduce that a little bit first. So what I want to the way I want to pose this, the need for data, is because of what the official data about the medical system say. So if you look at the productivity growth rates in the economy, they average, one something. And healthcare is always a very low productivity growth industry. Here it gets grouped with social assistance, just at the high level it does that, but most of that is healthcare. Here it's very slightly positive. That depends on the period of time. In many periods of time, healthcare is negative productivity growth. And so what that literally implies is that for roughly 20% of the economy, we're spending more and getting less if it's negative productivity growth. If it's zero productivity growth, that suggests we're spending more and getting nothing for it. And here it's we're spending more, we're getting a little bit more for it, but not very much at all. And so that's sort of guided policy. And to a sense that, to a certain sense that is indeed correct. That is, we are spending way more than we need to by international comparisons or any other comparison and not getting a lot for it. But I want to actually say it's really important to go even beyond that. And when you go beyond that, what you find is that these data are not representing the true state of the economy. And so the health economy. And so I want to sort of talk about that and go on and tell you a little bit about it. I should say that this is not a new topic, going back all the way with the Boston Commission in the 1990s and through many other activities. I've been a part of some of these. Murray has been a part of some and quite a number of people. There's been sort of well-recognized problems with gauging the medical system, the output and productivity in medical care. There are basically two big issues from a national income accounting. And as I say, this is not the only thing, but there's both the health sector at the public policy level, and there's also for clinicians and so on. I'll come back a little bit to the clinician one, but let me start with the public policy one. There are really two big issues. The first one is one of the things that Ariel mentioned, which is outcomes. That when we measure productivity is defined as an output scale, divided by an input. So we can measure the inputs tolerably well, like how much we're spending on medical care and so on. I'll come back a little bit to that, but the outputs are actually very difficult because the outputs are typically measured by things like how many surgeries do we do, or how many days in the hospital do we have, or how many outpatient screenings, imagings do we have, whereas those are not really the outcomes that people care about. So the first outcome the most important outcome that we care about is our improved health. So let's just take an example. Suppose we develop a new surgery that allows us to cure more people, like a new minimally invasive cardiac surgery that allows us to cure more people, or even a new drug that prevents people dying from COVID, or a vaccine that prevents people from dying of COVID. The aggregate productivity implications, by the way, of the COVID vaccine are approximately zero because it's not, we don't measure the outcomes well. The outcomes there are in length of life, quality of life, and we don't pick those up. Same thing with the surgery that I'm thinking about here. We don't pick up the length and the quality of life. So that's the first big problem, is that if you want to accurately gauge the sector, you have to do that. And I think this is probably related to some of what Shane was saying. This is not that different from things like, how should we gauge the productivity of the computer industry? Not just by how much we spend per box, because the box does a different thing over time. You've got to say, well, how much do we spend per thing that the box does? And so per thing that the box does is kind of like per thing that the surgeon does when he or she cuts you open. And that's the outcome here, improved health. So that's the first one, the improved health. But there's actually another problem as well that I think is equally large here, and that's substitution across treatments is not well accounted for. So the way the current accounting works is that there are industries within healthcare. There's sub-industries within healthcare. So hospitals is one sub-industry, and physicians is one sub-industry, and pharmaceuticals is one sub-industry. And those are treated kind of the way that bananas and breakfast cereal and meat are treated. That is, consumers value them, and getting more bananas is good, and more breakfast cereal is good, more meat is good, but God forbid you don't really trade off between breakfast cereal and bananas. That's not really a thing. And meat and breakfast cereal, you're not really trading off there. Whereas in healthcare, when we do that, so let's say we develop a new drug that allows us to cut surgeries. So we don't need as many surgeries because we can do the thing with the drug. Actually, aggregate productivity does not change. Let's say the drug is cheaper than the surgery. Aggregate productivity does not change because per drug, we're spending the same amount. Each drug costs the same amount, and each surgery costs the same amount, and we're just getting fewer surgeries and we're getting more drugs. And that's because people's preferences changed and they like drugs and they didn't like surgeries. But that's really the wrong way to look at it, because the right way to look at it is relative to the outcome, which is not a surgery or a drug. The outcome is improved health. Relative to that outcome, I'm spending less to achieve that outcome. Another way to put it is that, to a first approximation, people don't care at all about how they're treated. They care about what is the outcome of the treatment. And the reason why I'm stressing this is hugely important. So without this, you make a lot of big mistakes. So one thing I'll talk only briefly about it here because Mary's going to talk a lot more. Pharma spending is going up and that's bad. So that's a very common thing that you hear. And I did a paper along with a number of others saying, well, not quite so fast, because in some cases of pharma, what it's doing is it's actually preventing surgeries. Exactly, that's why I gave you that example. So antihypertensive drugs and cholesterol lowering medications have led to very big reductions in the amount of hospitalization that people need. And unless you recognize that, you're going to say, oh my God, we've spent more on prescription medications. That's a bad thing. That's not the case of all spending. For example, spending on opioids was probably a pure waste because not only did it not improve people's health, but it actually got them addicted to opioids. And so it's not universally the case, but it could very well be the case. By the way, we didn't show productivity reduction from opioids, which we probably would have. Or another example, if all you care about is the spending, you say medical spending fell in 2020. The first time we ever saw this, medical spending is actually lower in 2020 than in 2019. People didn't go to the doctor or all sorts of stuff like that. Well, that's good, of course, because if all spending is bad, then spending less is good. But then, of course, you sort of start to say, well, I suppose that's not quite right, because, what if it is that people are not getting services they really needed? And, maybe lots of hospitals now say they're full because at least some of it is because people are, catching up on the things that they didn't get that have now turned into more severe conditions and so on. So again, without being able to account for what you're getting for the outcome and those various inputs, you wind up drawing wrong conclusions and making bad policy as a result. So to me, the key questions are, why is spending growing? And how is the change in utilization affecting health? And in particular, this last one is important both for public sector and also when we're talking about, what we need to make good medical care decisions. We really need to know how is utilization affecting health. And then for the economy as a whole, and for thinking about healthcare productivity and thinking about productivity of different providers, we need to know about spending growth. Normally what we do is we sort of draw a distinction between prices and quantities. So we say, I want to know why car spending is going up. Is it that each car costs more, that we're getting more cars? Here there's another category, which is, and it's in the car as well, which is the service mix. So think about the service mix as, are we buying more SUVs or more subcompacts or more electric vehicles or whatever it is? It's a different type of service. I'm still buying a service, but which type of service that I'm buying, in that case, which type of good am I buying may change. And so this is an example of, maybe I'm getting an MRI instead of an X-ray, or maybe I'm getting one drug instead of another drug. I'm still getting a treatment, but the mix of the treatments is changing. And these are the sort of three things that we really want to know. How much is a pure price change given the service mix and the treatment? How much is more people getting treated, and how much is what the treatments are changing over time? So that's to understand why spending is growing. I need to know that. And then to be able to talk about productivity, I need to know the outcomes, and I need to know how is utilization affecting health. That is very difficult here because there's so many other things that are going on. So if you're not careful here, you'll find that that more utilization kills people. So for example, if you have a group in the population that's smoking more, you'll find they have cancer more and they're dying more. And they're getting cancer surgery more and they're dying more. So therefore you'd conclude that cancer surgery obviously kills people. It does kill some people, but that's not the right conclusion. The right conclusion is you need to separate out other things that are going on in the economy, both economic and demographic. And so I'll talk very briefly about that. I'm not going to spend much time on this other than to say that this is something that has been thought a fair amount about. This is from my work, but there are a number of other people who have done things on this. But basically what you want to think about is, sort of two types of conceptual inputs, or two types of conceptual foundations here. One is the inputs to health, things like medical care, behavioral risk factors, environmental and genetic factors, and so on. And then second is the outcomes, of which the one I've spoken about the most is the health outcome. That's probably the most important. But a second one, and this is I think what Shane was getting at the very end, if I got the thrust of what he was saying, which is that some medical care also affects your earnings. So for example, medical care that allows you to work longer, or in his case, technology that allows you to work longer, but anything that lets you work longer or more efficiently will increase earnings as well. To have those inputs, you need to bring them together to talk about aggregate trends in the medical sector. What are we spending and what are we getting for it? And then what you need to do is divvy that up to understand it. And here I'm going to make a big difference from what the national accounts do, which is an industry in the national accounts, as I was talking about, is pharmaceuticals or hospitals or physicians. Those are not the right industries here. The right industries are diseases, so conditions that people have, heart disease and cancer and mental illness and so on. So I want to think about those as being the industries, and then the medical care acts on people who are in that industry. I'm in the cancer industry. I'm a consumer in the cancer industry. I hope no one is. And how does that then affect, how does the medical spending affect what my outcomes are and so on. When I do this, sorry, let me just take a sip of water. When I do this, one of the things that happens when I do this is I find overall very big positive productivity improvement from healthcare, in part because health has improved a lot over time, and that's not picked up in the national accounts. And not only has health improved, but the improvement seems to be in many cases due to medical care advance. And that's particularly true of things related to cardiovascular disease. So heart disease mortality has fallen enormously. Healthcare is a big part of that, and that leads to a big overall increase. There's been other benefits for other sorts of things. So you can see here, anything to the right, farther to the right, is a high benefit. Anything close to 0 or negative is a low benefit. So other types of things, certain types of cancers have done very well, particularly cancers where you can do some screening for them, like colorectal cancers have done very well. Breast cancers you can do screening for. Other things we've done very poorly with, these are things about musculoskeletal things, particularly spending a lot of money on opioid meds that haven't done well for people. So there's an enormous amount of heterogeneity. That heterogeneity is important to understand, because that's really a statement about where are we doing well as a health economy and where are we doing poorly, and therefore where should we be thinking about, okay, we need to make a change here because we're spending a lot of money and not getting a lot, or where are we spending a lot of money and getting a lot, so therefore we just want to think about continuing that sort of stuff. So this heterogeneity, as it is in any set of industries, is really important to take account of. You mentioned a lot about the data that we have, and I'll sort of, and they've not really made their way at great length into our official numbers. So I'll say two kinds of data that would be really incredibly valuable. One is real-time access to medical spending in large samples. So think about, can I get insurance information on everyone who's insured by several of the big insurers? I need to match people over time because I need to get a picture of people, not a picture of insurers. And I need to decompose it, as I said, to the condition level. I want to know what services are performed, where they were performed, what was paid, all that sort of stuff. These data generally exist. Most medical data that we have easy access to or ready access to are from medical claims. So anytime someone wants to get paid, they submit this sort of information. The tougher part is this middle part here, which is the individual characteristics, which you need to tell why health is changing. So you need to know about things like smoking and obesity and pain and so on. My hope is that we'll tend to get some of these from electronic medical records and or other kinds of surveys that we can get from people relatively readily through smartphones and things like that. But we'll need to go beyond just what we know about for billing purposes, which are, the billing purpose data are great to have, but in order to go even further, we'll need to go beyond that, and to get the outcomes, we'll need to go even beyond that. And that's what's coming in down here, which is periodic supplements with outcome information. We're not going to get this on as quite a real-time basis, and some of the outcomes that we care about are not just point in time, like we do cancer. We think the cancer operation that happens today is better than the one that happened last year, and we hope that'll show up in higher longer-term survival. Not just in survival today, but in survival down the road. So that requires knowing down the road and then coming back and ex post doing an adjustment for outcome changes as we do productivity. But that's not an unusual sort of thing. We learn about lots of productivity things, not just at the point in time, but down the road, and we go back and we do readjustment for it. But these are the two kinds of data informations that I think we would really want to have. Some of these we can get from things like registries and so on, or just by following individuals and using the types of methodology that we have over time. So from either medical claims record or registry information and so on. And I will stop there.
Terrific. Thank you. Thank you very much, David. One thing that occurred to me when I sort of was looking at your slides, you talked about a 1.5% set of productivity growth rate.
Yes, it is.
I mean, do you feel that to sort of be high, low, what you expected, I mean, if you were thinking about the performance of the healthcare system, how do you construe that? Because, well, why don't you say that? I can tell you my reaction.
So I think so if you compare it to industries, it's typical in the economy. So it's not up there with high-tech industries, but it's fairly typical. One of the things that interests me about it is that for some conditions, it's super high. And for others, it's basically zero. So it's like the economy as a whole. Some things are like the cardiovascular stuff is just immensely high productivity. And then we spend $1 gazillion treating people with pain with drugs that are not only not helpful, but actually harmful.
So that's kind of the implication of you dividing the conditions into industries, that we should actually think about this not as the healthcare industry, but as the cancer industry, the cardiovascular industry, the mental health industry. And so the question, even kind of asking the aggregate number, is not necessarily, perhaps the most important thing for policy about this process is changing the framework for asking the question.
I believe that's entirely correct. And I think there's very little good that comes anymore from saying an industry is a hospital, an industry is a doctor's office, an industry is a pill. And because that's just not relevant. There's no individual, if you said to someone, you no longer have to go get an image, you now do this other thing, they'd say, great, just tell me what I need to do, what improves my health. And so, but here's my problem. I've got this condition. And that's what I want you to do, is make that condition be better. So the industries really have to be based on the things that people value. And that what they value is the treatment for their disease.
What would you, I mean, I'm sure you're already sort of giving advice to the statistical agencies on what to do now. What would you tell them, okay, in terms of improving changes that would improve policy?
Just to jump back here, do whatever you can. Let's try and build up our information here. So first, think about conceptually doing this. And by the way, BEA has been terrific in terms of thinking about conceptually redoing it. So they've actually done a lot of the research, and they've been way out front on this, which is just great. And then let's think about how can we systematically get more information on these. Many of these are out there. We can get them. We can try and put them together somehow. It's going to be really tricky because people flow back and forth across different systems. So like, for example, Medicaid, Medicaid is a little bit of a black box in terms of the data, and people are not always on it. They're on Medicaid, then they're on private insurance, then they're on some other thing. So the like assembly of the individual level version of this is going to be complex. And then trying to get some of the outcome information. And this is going to come with a bit of a lag, obviously, but still thinking about the investment in that.
I'm always interested in the ability of new data to sort of pick up problems that we are not aware of. Would this sort of structure have picked up the opioid crisis before it sort of got out of hand?
It would have certainly helped us to. So one of the things that the opioid crisis, it was the first inklings of the opioid crisis were actually apparent in the late 1990s. And when you started seeing people coming into hospitals with more opioid-related overdose issues than had been in the past, but we didn't have any big systematic look at it because we weren't collecting these data on a real time. Or just to give you another example, how does it, at the moment, South Africa is better at figuring out what's happening with new variants of COVID than the US is, because they have a much more systematic kind of testing structure and reporting structure and assaying structure and so on. So we have very little idea. The countries that did best in COVID were the ones that were testing regularly, had centralized collection of it and so on. And they made decisions that were evidence-based, not decisions that were based on what they hoped was true.
So part of this is such an obvious example, is this enables us to spot problems sooner that we weren't even expecting, or maybe that we were expecting it, but had no idea when they would come.
And in fact, a large number of drugs that are withdrawn are withdrawn because ex post we observe poor outcomes that there was maybe a slight hint of in the clinical trials beforehand, but we didn't have big enough samples. And it's only when you get big samples ex post that you then learn about it. So the real-time learning is really, really important. It's important for policy. It's also, by the way, really important if you want to go to a doctor and talk about what they do. So having 3-year-old data, when you go talk to a doctor and say, why are you practicing this way? They'll say, that was 3 years ago. That's like, don't tell me about that now. That's, that's water under the bridge. The world is different now. So you got to be able to say, oh, and by the way, 3 weeks ago, here's how you were practicing. And this is not the way the guidelines suggest and stuff like that. So that real data is important at all different levels.
Well, interestingly enough, this conference will conclude with John Halterwanger talking about real-time data, okay, which sort of fits right in. So is there anything else you'd like to sort of sum up with at this point?
Just one other thing on the real-time data, and John will certainly be in a great position to talk about this. We did a number of surveys right after COVID started, the household pulse surveys and things like that have actually been enormously important, both in health terms. So we get a look at what's been happening to mental health of the population, which unfortunately got a lot worse during COVID. Also things like food insecurity and stuff like that help us get really, really up-to-date data that then helps us guide policy about, what should we think about policy with respect to the medical system? Do we need to be thinking about more counselors? Do we need to be thinking about nutrition programs and so on? So that's actually been an example in the health and social sphere where the real-time data has, I think, proven to be terrifically helpful. Maybe John will disagree, but I found it to be very, very helpful.
Well, this has been terrific, David. Thank you so much for agreeing to participate in this, and I'm sure that it's been very helpful to a lot of people.
My pleasure.
Thank you very much. So our next presenter is Murray Aitken. Hi, Murray. You're muted. Ariel already introduced you, and so I think you should demute yourself.
All right, I'm demuted, and I believe you can see my slide.
Very good.
Good, thank you. And well, David's always a hard act to follow, but I do appreciate this opportunity to sort of share our perspective on what we see happening in terms of the effective use of data for policy making as it relates to drugs specifically. So I'm only looking at things through a very narrow lens, and some might say that this should be the easy part of healthcare to measure. What do we spend on drugs? How much is it costing, and is it going up or going down? But as I'll explain, it turns out that proves to be perhaps more difficult than might be expected. And that's without really talking about outcomes. Again, as David says, that's really what we should be talking about when we are looking at healthcare expenditure and its impact. And that's another whole level of complexity. So, I'm going to be focused on the easy part, and take you through kind of what we observe. Just sort of level set the perspective that I'm bringing. So I'm part of IQVIA, which is a large global company that gathers vast amounts of healthcare data, non-identifiable data, and puts that together using technology and our capabilities to try to be able to look at the total market and the total use of medicines, not only in the United States, but around the world. We're a private sector company, and so we work independently, if you like, of other parts of government that gather data. We're also not academics, but we, but we observe how data gets used and how policy making uses information, and I think it's an area that we have concern about, and recognize that there is a lot more that could be done with the data that actually is available. So let me take you through the slides. I mean, let's just start with the big picture. How much do we spend on drugs in the United States? And, you know, not a difficult question. And the National Health Statistics Group at CMS usefully puts out their answer to that question, which tends to show up as depicted in this slide. That would say prescription drugs, 10% of the $3.8 trillion national healthcare expenditure. They do, if you look into the definitions, define a little bit what they're including in that 10%. And immediately you'll notice that they talk about retail sales of drugs, which is perhaps a clue to some of what's missing there. But that tends to be the headline number that gets used a lot. Are we spending too much on drugs? You know, again, the rhetoric and the headlines would be pretty clear in saying, yes, of course we do. And, you know, payers will point to how much of the health dollar from their perspective is being spent on drugs. We see policy proposals coming certainly out of Congress, but even, you know, by payers to try to make prescription drugs more affordable, which suggests, or I'm inferring suggests that we are spending too much. Of course, it's a given that we spend more than other countries on drugs. Again, the rhetoric and the headline tends to focus on that. Though if you actually go to the OECD's website and take a look at pharmaceutical spending as a percentage of health spending, actually it looks like we're below the median in the among the OECD countries, which is perhaps a little bit of a head scratcher. The other question that actually we like to ask is, you know, does the non-retail matter or not? And again, that goes back to that initial slide, which CMS tells us is focused on the retail drugs. Does non-retail matter? And this is some actually unpublished work that we've done, where we've actually taken the OECD's numbers, which it turns out from their prior slide are really focused on retail distribution of drugs. We've made some adjustments to that for some limitations of their methodology. And then we've added on in the dark part of the bar, the non-retail expenditure on drugs, and then put all that over as a percentage of total healthcare. And again, you can see that the delta between retail and total, the non-retail part, also differs quite significantly across this set of 11 countries. And that's something also to note, that, you know, even when we are using the same terms, in this case, in different countries, we're actually looking at very different things, whether you're in Italy and the way that drug distribution is characterized there versus the way it's done in Canada or Australia, or indeed in the United States. So if we take sort of all of that, we would, you know, make the point that a lot of the differences between the various numbers that do get thrown around in response to the question, how much are we spending on drugs and what share of healthcare expenditure is it, are attributed to, you know, a few sort of big buckets of differences, which we can think about in terms of what's measured as a drug cost. Is it retail? Is it retail and non-retail? Are rebates importantly included or not? Is this about patient out-of-pocket cost or some other cost? What about costs and administrative costs and margins? You've got a denominator as well, healthcare cost. What's in there? That's particularly important when you're comparing across countries. And then what population are we talking about? Are we talking about the entire national population? Are we talking about it by different payer group? Are there exclusions somewhere that's been used and over what time frame? So we've done some other work that we've published, really trying to decompose the drivers of the differences that we see when this drug share of healthcare cost is being talked about. There's other work that we do within the IQVIA Institute in an effort to try to explain the what some might say is unexplainable or inexplicable difference between what's going on in the US between drug expenditure looked at on a list price basis and on a net price basis. And this is where the whole issue of quote unquote rebates come into play. So this is a view that we have in our annual trend report that we do on the use of medicines in the United States and the expenditure on those medicines, that crosswalks between what is referred to as the list price for all drugs used in the United States in 2020, measured at the wholesaler acquisition cost, which is essentially the manufacturer's list price, and what payers end up paying on a net price basis. So that goes from $697 billion in 2020 to $449 billion. And then there's another way to look at it, which is crosswalking from that list price expenditure of $697 billion to how much do manufacturers receive as net revenue. A lot of the debate around drug pricing is on the manufacturer view, how much are manufacturers making. And one of the things that we've done for many years is really tried to explain what is it that actually ends up in the revenue line of a manufacturer, and what are the big differences? And there's a couple of big differences. One is what's referred to here as on-invoice discounts, which is really a reflection that the higher the list price, the more money many intermediaries make in the system. So list price is the basis for a lot of other charges that occur in the drug distribution system, from the manufacturer warehouse through to the patient, and that's what people refer to as sort of the built-in incentive to keep raising prices, because quote unquote everyone makes more money that way. There's also the rebates, the sort of off-invoice discounts and rebates of about $112 billion. That's what gets negotiated with plans or PBMs, between the PBMs or the plans and the manufacturers, and that is all subject to confidential arrangements. So it's not a sort of publicly disclosed number. It's one that we do a lot of modeling on to come up with, but which is an important and large part of the story here. There's another piece of here which is the patient out-of-pocket costs. We calculate that overall patients spend about $77 billion out of their pocket when filling prescriptions, or that's their share of their prescription drugs used in a hospital or a clinic. That's less than it would have been because there are manufacturer coupons of about $14 billion that offset some of that cost, but that's another piece of the puzzle, which is also important. Looking at these different price points does give you different trends in terms of what's been going on. So this is our sort of 10-year trend, and if we start at the top, that's the WAC pricing level that's been growing for the last 5 years at a 5.1% compound annual growth rate. The manufacturer net, as you can see, lower at 2.9%. The patient out-of-pocket cost, that's also been rising slowly. But again, these are different dynamics, and you can also see that the the difference between the WAC and the manufacturer price, this delta here, has been growing from about, if you go back to 2013, that's about 160 billion, and now it's at about 240 billion in 2020. There's also, it's important to understand what's going on below the surface too, because it's easy to talk about total expenditure. This is a way that we break out the drivers of change in drug spending. The impact of new brands being introduced into the market, which is shown here, added $62 billion in spending over this 5-year period, 2015 to 20. We had price adjustments. You can see relatively small, and in fact, in 2020, it was a reduction, a net reduction. We had volume, which also is where the mix of drugs that David was talking about shows up. Then we have the impact of the loss of exclusivity, the so-called patent expiry, where we see less being spent on branded drugs because they now face competition from small molecule generics and now increasingly from large molecule biosimilars that reduces spending by 78 billion. And then we have the impact on what's going on in the generics market. So again, from our perspective, understanding these individual drivers and how they are playing out is also important from a policy perspective. This is a view that we publish on the difference between the WAC price increases on branded drugs each year and the net price that the manufacturer receives at the end of it. And again, that delta is any incremental or different level of rebate that is being negotiated away. And again, you can see the trajectory of those lines. Let me just close by sort of reflecting a little bit on what we think about in terms of improved drug expenditure statistics. First point is knowing what is included and excluded seems, again, rather basic, but rather important. And again, when we see what gets thrown around in policy discussions, this is always not very clear or made explicit. Understanding whose cost is being measured. Are we talking about the patient cost? Are we talking about the wholesaler's cost? The end payer cost, the pharmacy cost? These are all at different levels and they move somewhat independently, and being explicit about that is critical. Recognize the role of rebates, including the sort of cross-subsidization, if you like, that occurs, including through programs like 340B, that we think is also more significant than people tend to recognize. Timeliness is important, and then forecasting, anticipating what's ahead, understanding those dynamics that I talked about and how they're likely to play out, and building that into sort of policy relevant analysis is important. And then the final point I would point out is that we spend a lot of time tracking what money is spent on, what drugs are being consumed. We don't track as much as what isn't being spent, because the prescription was not picked up by the patient at the pharmacy. It was abandoned, or the prescription wasn't refilled, or there was a delay in the treatment. And we think those are important as they link to health outcomes. We don't do a very good job anywhere of tracking that. And certainly, as I point out on the right-hand side, we aren't tracking those outcomes. This is where you can get more information, and I welcome if we have time for any questions. Thanks.
That was a fantastic presentation. I want to say that I find your reports, I'm an avid reader of your reports, and I find the data in them to be exceptionally useful for understanding what's happening in the healthcare system. Let me ask you one question about your net price measure. Do you think that this is something the government, speaking not in terms of your business, okay? Do you think that this is something the government should be calculating? Could they do would they have access to the information that they need to calculate net prices?
That they could. I mean, it's not a complete mystery. And I would say over the past 10 years, a lot more people, in addition to ourselves, are sort of piecing this together in order to reflect what's going on a net price basis. I might say at some point, the manufacturers didn't want to talk about net prices because they like to actually make it look like their prices were going up. I think in the last decade, we've definitely seen a shift in that. And now even the manufacturers themselves are publishing a lot more about their
Yes.
net prices, because I think they also see that it's better to have that out there as context for some of the discussions about the level of drug expenditure.
Do you think we need more transparency in the pharmaceutical price system?
Well, I think we need more understanding. I'm not the person, David, maybe to say whether more transparency leads to lower prices or indeed higher prices. But I think we definitely need more transparency in terms of understanding what's going on and utilizing the data and the statistics that do exist when considering policy changes.
Well, thank you very much. This was absolutely terrific, and I'm so glad you were able to participate.
Great.